Shall we start? Okay. So it gives me great pleasure to introduce my dear colleague and friend Alison Lim. Allison is a very, very rare species. She is a physician scientist. She's a clinician. She's a healthcare services researcher. And she also got her Bachelor's of Science in Chemical Engineering and Economics at MIT. So, well, that's where she started. And then she went to Yale for her medicine and then did her residency in 2 places in Western Psychiatry Institute as well as in the University of Michigan. When Allison and I met, she was a resident, right, mm-hmm. Allison? And that was not a long time ago. And so, and then she did her 2-year fellowship in addiction psychiatry. It was both a clinical and research fellowship. And then she was, there was a battle between several universities to recruit Allison, and University of Michigan won. And so she's an assistant professor there at the University of Michigan. She's also a staff psychiatrist in the substance use disorder clinic at the VA Ann Arbor Healthcare System. That's where we first met. And a research investigator in the CCMR, which is the Center for Clinical Management Research, which is a HSR&D Center of Excellence in the VA Ann Arbor Healthcare System. So Allison is interested in systems-level intervention to improve access to treatment, quality of treatment, and outcome for patients with opioid and other substance use disorders. She uses large data sets to understand clinical challenges in treatment environment, and is also interested in developing interventions, particularly telehealth, to expand access to effective treatments for patients with substance use disorders. And in fact, she has a VA Career Development Award using Telemental Health for buprenorphine. And I'm really excited to hear more about it because when I left, she was just submitting her proposal, which I had predicted would be funded the first shot, and it was. And she's also a co-PI on an NIH ROM enhancing the impact of behavioral pain management on medication-assisted treatment outcomes. So without much ado, I'm going to ask Allison to come and share her work with us.
Thank you very much, Brian, and thank you very much for that letter of support, which helped me get my Career Development Award. I think I can put this down, right, and hopefully everybody can hear me. Thanks very much for that introduction. I'm very excited to be here in San Diego, mostly because, as you guys were saying, it's pretty chilly for you, but it's very warm for me coming from Michigan. As Brian said, I'm an addiction psychiatrist, but also addiction health services researcher. There's not a whole lot of us around who do health services research within addiction, so I'll just mention briefly. So unlike folks who do basic science research or who do clinical trial research, my area is really how do we take the current treatments we have and improve the delivery of them so that more patients can receive them and that patients can have better outcomes by improving our healthcare systems, the policies that we use, etc. Today, much of my research is really in the area of the opioid epidemic, as well as generally improving care for patients with substance use disorders. But today I'll be focusing on improving treatment access, as well as the quality of care for patients with opioid use disorder. I have no financial disclosures. As always, these are my own views. They don't represent the VA or any other organization I'm affiliated with. An outline for today. So first, I will start with a very basic background of the opioid epidemic. I know probably folks in the audience range widely in terms of kind of your backgrounds and knowledge around opioid use disorder and challenges. But I'll focus a little bit on the background, but mostly I'll talk about how the epidemic has evolved in recent years and really focus on what are the current challenges. I'll describe these current challenges organized into 4 main areas. So first is how do we deliver treatment to populations most in need right now. And that might include using telemedicine and other forms of technology and other treatment models to increase treatment access. Third is how do we better support providers to get more providers to start delivering treatment, and also how to support current providers so that they can deliver more treatment and also better treatment to patients in need, especially with the medication buprenorphine. And lastly, how do we improve the quality of care and patient outcomes? So we always think about more, but we really need to be thinking about this at the same time is how do we deliver more treatment that's actually high quality and will result in better outcomes. So this is a very simple figure. This is a figure of opioid overdose mortality rates released by the CDC. I'm curious how many folks in this room have seen this figure before or something similar to it. Okay, most folks. Good. So I'll just briefly reiterate it because I still think it summarizes kind of the trends very well. So what we saw in the 2000s or so was a rise in prescription opioid overdoses. So that's represented by the light green line labeled natural and semi-synthetic opioids. However, and that's mostly related to the dramatic increase in overprescribing of prescription opioids that really lasted from the 1990s up until very recently. However, in the last 5 years or so, you really see these huge increases in rates related to overdoses with heroin and also synthetic opioids, which nowadays are mostly illicit. So they're not from prescribed fentanyls, they're actually from illicit fentanyls mixed into the illicit drug supply. There remains ongoing debate for why we see these shifts in trends. I would say that the underlying hypothesis, though people may disagree a little bit about this, is that there are a number of contributors. One is the increase in the drug supply of illicit drugs, opioids, methamphetamine, especially in this area. And second, related to that, is the drug supply of illicit drugs has really increased in potency. So when I talk to patients nowadays, and you guys probably see those patients in your substance use disorder treatment programs, they'll say the heroin I use today is very different from the heroin I used 20 years ago. People, could use many times over 20 years ago and have very rare overdose events, whereas nowadays it happens much more frequently due to the potency of the opioids involved. But to take one step back, just to remind ourselves, why are opioids a problem in the first place? We probably should have known this all along. This is a very simple slide, but this kind of explains why we've kind of gotten into this trouble. So we know that chronic pain is probably one of, if not the most prevalent medical condition among American adults. And then, over the last 20 years or so, we started to set up the expectation that we treat all pain, whether it's, a sore throat or a broken ankle or a major surgery, with opioids. The problem, though, is that opioid receptors are highly concentrated not only in pain pathways, even though they're not very good at treating pain, especially chronic pain, but they're also highly concentrated in the reward pathways, which underlines all addictive processes. And finally, they're also highly concentrated in the brainstem, which is why an overdose of opioids can cause people to stop breathing and thus die. With that as background, kind of the thing that I most want to emphasize today is that given kind of these trends and shifts, what we really have seen is a shift towards really patients most vulnerable to overdose are those who are using illicit opioids who've developed an addiction to opioids, some of whom might have comorbid chronic pain and other comorbid mental health and other medical illnesses. The most important thing that we can really be thinking to address this epidemic right now is how do we deliver more treatment and effective treatment to patients. The good thing is that we do have effective treatments to date for opioid use disorder, and these are the three medications: methadone, buprenorphine, and long-acting naltrexone. Methadone has been available for the longest. It was approved in the 1970s by the FDA to treat opioid use disorder. Important thing to note, though, is that methadone can also be used to treat chronic pain, but when used to treat patients with an opioid addiction, it can only be dispensed out of methadone clinics. So it doesn't come as a prescription, which is how we normally get most of our medications, but it comes as actually a dose dispensed by a nurse at a methadone clinic, oftentimes on a daily basis. And because methadone clinics, there aren't many methadone clinics in our communities, it can oftentimes be very difficult for patients to get to them, but also to continue to go, especially when it requires such frequent dosing. Then in 2004, the medication buprenorphine came to be approved for use and treatment of opioid use disorder. Buprenorphine is also an opioid, but in contrast, in part because of its safer side effect profile, it's allowed to be prescribed in outpatient clinics. So, as a provider, as I can prescribe any other medication, I can also prescribe buprenorphine in outpatient clinic environments, whether they be in specialty treatment settings or mental health or primary care settings. And what's required is that providers have to be physicians, NPs, or PAs, have to go through some additional training, and then obtain an X waiver through the DEA. Finally, or these two medications, so methadone and buprenorphine, like I mentioned, are both opioid agonists themselves. Pretty much every talk I give, I get the question, aren't you just trading one opioid for another? And the key thing to remember is that addiction is not just a disease defined by the substance itself. It's really a disease defined by the symptoms, which are the behaviors related to addiction. When patients are stably treated, doing well on these two medications, these medications help reduce cravings and urges for people to use opioids, reduce the euphoric effects of opioids if they're used concurrently, and also reduce withdrawal effects. So it gives someone the amount of time to kind of regain their life to where it once was and to regain the functioning. And that's how they treat kind of the underlying disease of addiction. In contrast, the third medication, naltrexone, comes in two formulations. It comes in an oral once daily dosing, also comes as a once a month injection. It's the once monthly injection that's been shown to be effective for opioid use disorder, also called Vivitrol. And it works differently. It's actually an opioid antagonist, which I'll mention in the next slide. So this graph kind of summarizes the differences in how these three medications work. So like I said, methadone is a full agonist in contrast to buprenorphine, which is a partial agonist. And what that means is that even at the highest doses of buprenorphine, the potency or the full effects are going to be less than methadone. One of the benefits of that is that although these are both opioids, as a partial agonist, buprenorphine has much lower risk for overdose. So even if someone unintentionally takes a large amount of it, the chance that they die from buprenorphine alone are very low, though that might increase if they use it in combination with other substances. And the third medication, it's labeled naloxone, but you can think about it similarly with naltrexone, which are both opioid blockers or opioid antagonists. They work because if someone has this medication on board, even if they take additional opioids, they're not going to feel the euphoric effects, and that's supposed to deter use. So regardless of all of the, regardless of any of these medications, the goals of treatment are the same. It's really to reduce some of the symptoms of substance use disorder, prevent cravings, reduce the risk of relapse. Notice I don't say eliminate it altogether, because we know that's probably not very realistic, given that this is a chronic illness. We know that folks are going to relapse, but we know that these medications can dramatically reduce the likelihood of relapse or increase the time to relapse. But most importantly, I think of when I see my patients and what I talk to them about is really that these medications are there to help you regain your functioning, regain the life that you had. When we think about substance use disorders, when I work with trainees like residents and med students, they oftentimes say, oh, does this person have a personality disorder? And oftentimes when you work with these folks long enough, you'll notice that after they're stable, they might no longer appear like they have a personality disorder, which is what addiction can honestly confer in the active phases. And the goal of treatment is how do you kind of help that person recover kind of their daily lives. So there have been many dozens, if not hundreds of studies looking at the effectiveness of these three medications, particularly methadone and buprenorphine. There have been multiple systematic reviews, meta-analyses published in JAMA, internal medicine journals, etc. I'm just going to highlight one. This is actually not an RCT. This is a cohort study that was published in the Annals of Internal Medicine last year by folks at Boston Medical Center. They looked at the entire population of people in the state of Massachusetts who had survived an opioid overdose. And then they followed from 2012 to 2014, and then they followed this group of people 1 year afterwards. They wanted to see what happened to them, what treatments they got, and what were the effects of these treatments. What they found is that although all of these folks had experienced an opioid overdose, so the highest risk population, only 3 in 10 of them actually received one of the effective medications. It's a very low rate. If we're thinking about diabetes care, if we're thinking about, heart attack treatments, right? If we said only 3 in 10 of people who had experienced an MI received kind of the critical intervention, I think all of us would be up in arms. What they found, though, was that among those who received these medication treatments, for patients who received either methadone or buprenorphine, this conferred substantial benefits and reductions in all-cause mortality and overdose mortality. So a 53% decrease with methadone and a 37% decrease with buprenorphine. With naltrexone, they did not find any significant changes. That might be both either due to the treatment itself or potentially due to the lack of sample size. But I just wanted to show this because there are very few treatments we have in psychiatry that have been shown to have a mortality benefit in a large kind of population like this. In addition to this, obviously, there have been many studies that have looked at many other outcomes that we care about. We know that these medications not only reduce overdose rates, they also reduce opioid use, they improve HIV and Hep C outcomes, as well as other kind of risky behaviors. There's also been recent evidence suggesting that these are cost-effective treatments and they improve quality of life for patients. The bottom line is that medications are the most effective treatments that we currently have for opioid addiction. Without medication treatment, on average at least, patients have much higher rates of substance use and overdose rates. That doesn't mean that psychosocial treatments are not helpful or effective. This means that on average, however, what we should be really considering and offering are some of these medication treatments. So I know that a couple of folks in the audience are clinicians, but maybe others are not. So I just wanted to give a very brief vignette of what it's like to treat patients with opioid use disorder and hopefully dispel some of the myths. So what it's like. So I see a patient, Mr. S. He's a 44-year-old male with a history of hypertension, depression, and chronic pain who presents to clinic to get help for his, quote, problems with opioids. He reports that he was started on hydrocodone by his primary care doc 7 years ago after a work-related injury. He first took it as prescribed, but also noticed that it seemed to help with his mood. And he started taking more of it than prescribed. And over time, he was finishing a month's prescription in a few days and started to snort the opioids to get a more potent effect. He's tried heroin, he's missed a lot of work, and his wife has been very concerned. He comes in and he says, I can't do this anymore. I feel like I'm about to lose everything, but I'm afraid to stop. I know this is just a very simple vignette, but my guess is that many clinicians working with this patient population have had very similar experiences. This is not atypical at all, that a patient was first exposed to opioids many years ago by a prescription opioid, but now have developed problems that kind of supersede that. It's a subpopulation, so not everybody who gets exposed to opioids will develop an addiction. In fact, it's probably a small proportion of people. But for those who do, they'll usually talk about how they felt really good. You know, most of us, if we take an opioid, we feel nauseous, you know, it doesn't feel very good. But for the proportion of the population where it really kind of hits that part in their brain, they're kind of off to the races from there. And the other thing that this vignette demonstrates that it's oftentimes very difficult for patients to come into treatment. So when I think of it is by the time someone has already arrived at my office, it took them a lot of steps. It was very difficult. Rarely is there a person who on a whim decided to come to treatment. It was usually after very begrudgingly after a long time, mostly because of some of the stigma and also due to kind of some of the misconceptions of what treatment is about. And it's really important, I think, for us to respect kind of how much work it took for them to even arrive at our doorsteps. So after you see this patient, you do kind of the basic assessments. Includes the history and physical. You check the prescription monitoring program, which is now available across pretty much, I think, all states in the U.S. You do some basic lab tests, including urine toxicology, just to have a sense if there's any other substances involved. He may or may not tell you about them. They may or may not matter, but just so you know, as part of the treatment plan. And you discuss treatment options. After talking through different treatment options, including different medications, different levels of care, the patient says, Doc, I'd really like to try buprenorphine naloxone because I really think that this would help me with the urges and cravings that have really prevented me from stopping. In addition, I really want to come to office visits. I don't think I can go to a methadone clinic. And so you discuss a treatment agreement, which is what the expectations are for treatment, how often kind of the visits might be, when they might be tapered out, what are the expectations for how long this person might remain in treatment, so typically for a pretty long time, depending on his history. Then you prescribe a starting dose. In this case, you do a home induction. So years ago, we were doing these very elaborate office-based inductions where I would observe, start a patient on a medication, have them sit in the waiting room for a couple hours, do an assessment beforehand and afterwards to kind of look at their withdrawal symptoms. Nowadays, from many years of experience in research studies, we know that this is by and large not necessary. There are some patients who are very high-risk patients that we might still do this with, but vast majority of patients, it's a medication that you prescribe and they take it at home. You titrate up their dose over the next couple of weeks. You might see them pretty frequently, like weekly at the outset, but then taper to every 2 weeks and then taper to every 4 weeks when they're doing stably. And then you continue this patient on a stable dose, for example, of 12 milligrams. This is kind of pretty usual. Dr. Marienfield, she might have very similar experiences. There are obviously more complex patients or different patients, but this is kind of a very, routine scenario.
I just have a question.
Yep.
When you're working with residents and you're teaching them about induction,
yep.
do you do in-house induction so that they can learn that, or do you go right off the bat having them do home induction?
So we'll talk about it. It depends on the patient. So I actually had an in-house induction last week, and this was a patient who was coming off of methadone. He had no prior exposure to buprenorphine. He showed up to our clinic being told by a provider who had given him his last dose, and he was in full-blown withdrawal, and it wasn't clear what dose and what else he was taking. So in that particular case, we saw him briefly after he took his first dose. He did great. And then a resident saw him afterwards in follow-up, and we kind of talked about it and such. So what I would say is that we talk about in-house inductions for certain patient populations, but we also talk about at-home inductions and when that's appropriate. Good question. And I know that might be different depending on different treatment settings. So if you're in a residential program, pretty much all inductions are in-house. Whereas in an outpatient setting or in a primary care clinic, it can be very different. So given this, we know these medications are effective. They've been around for a long time. Why do we still have a problem? So we do still have a problem, and there are kind of some major facets to it. One is access to treatment. So the estimates that I showed of Massachusetts are pretty similar across the country, some places much worse even. So the estimates show that less than 20 to 40% of patients with a diagnosed opioid addiction are actually receiving these effective treatments. Sometimes they're receiving other treatments that haven't been shown to be effective. Sometimes they're not accessing care at all. So there are a range of issues. And then the second piece is that even for those who get started on medications, retention rates are very low. So on average, retention at 3 months of treatment is about 50%, which is not great, mostly because we know that all the studies show that it's only, the benefits of the medications are only there when they're actually taking it and they're engaged in treatment. When patients leave the clinic, for example, if they are discharged from clinic, or if they stop taking the medications on their own, the benefits disappear. So a major question is, how do we kind of first understand what are the contributors to people stopping treatment, and also how do we increase this? And I'll talk about some of my work and some work from colleagues addressing both of these. And that brings me to kind of the 4 general areas that I think are the major challenges that we need to think about in addressing these major barriers. The first is to figure out, so given all these changes and trends and the fact that the opioid epidemic now is not the same as the opioid epidemic 5 or 10 years ago, who are the patients who are currently most in need of treatment? So we know that in addition to the changes and trends in overdose, the other thing that's changed dramatically in this country is changes in opioid prescribing. Opioid prescribing in this country has gone down dramatically. This is related very likely to a number of things. Some of it are national guidelines and policies. So the most well-known one is the CDC Chronic Opioid Prescribing Guidelines that was published in 2016 in JAMA. But then also within pretty much all healthcare systems. I know at the University of Michigan, within VA nationally, there have been major initiatives. In the VA, it's called the Opioid Safety Initiative, started in 2013, where the goal was really complex and multifold, but the ultimate way that it was construed by clinicians was, we need to reduce the number of patients on opioids, we need to reduce the dosage of opioids. And what we've shown through some of my work and work by colleagues, at least of the VA, is that these initiatives have substantially reduced opioid prescribing, especially high-risk prescribing. So high-dosage prescribing, morphine equivalents of over 100 morphine equivalents or 200 morphine equivalents, which are pretty high dosages. And also other risky prescribing, such as prescribing with concurrent benzos, have decreased dramatically. And these results are also paralleled in the country at large. That the number of patients who are now receiving opioids at high dosages have gone down substantially. They're probably still higher than what they were like in the 1980s, but they're definitely way lower than they were in the 2000s. One question, though, that we sought to address was, although opioid prescribing has gone down on average, has the receipt of prescription opioids among those at highest risk for overdose gone down? So maybe it's only gone down in people who are very kind of low risk for overdose. And so we, in this recent study, we looked at this question using the VHA population. We looked at the questions of what are the trends in both opioid overdose across the opioid subtypes, but also how has the receipt of prescription opioids changed among the veterans who died from overdose. This was recently published in AJPM with colleagues. And what we did was we took annual cohorts of veterans from 2010 through 2016. The denominator was all veterans accessing VHA care, and this is the unique thing that we can do in the VA. We have data on every single person. We know what happened to them, and we also know what treatments they received. This is really unique. There's no other healthcare system across the country that's a national healthcare system across the country where we can do some of these analyses. We looked at outcomes which were defined by different causes of overdose deaths, including unintentional, intentional death, homicide, and undetermined intent. And we focused specifically on opioids. First, all opioids, but then broken down by the 4 categories that I've shown in the initial CDC slide. So the natural and semi-synthetic opioids, which are prescription opioids, methadone, synthetic opioids, and heroin. We also looked at the receipt of opioid prescriptions from the VA within 3 months and 1 year prior to death. What we found was similar to what I showed of the national data. In veterans, the overdose rate has increased from 2010 to 2016. So the adjusted rate ratio was 1.65. However, the story is very different depending on the type of opioids. So in green is the prescription opioids, and we found that that did not change significantly over this time period, which in itself is not a good thing. However, we found that the rates for synthetic opioid overdose and heroin increased dramatically. So both of those increased about 5-fold in a 6-year period. That's a tremendous rate of increase for anything when we're thinking about mortality rates. At the same time, probably more importantly, we looked at the receipt of prescription opioids. We found that comparing veterans who died from opioid overdose in 2016 to those who died in 2010, the prevalence of those who received any prescription opioids within 3 months prior to death and 12 months decreased substantially. So it went down from 54% of veterans to 26% of those who died were receiving any prescription opioids. And this prevalence is even lower for those who died from synthetic opioid overdose and heroin overdose. So this is very much a descriptive study, but I think there's some key implications for it. One is that our overdose prevention efforts have to really broaden beyond patients actively receiving opioids. So if you look at a lot of our healthcare systems, including my own at University of Michigan, many of the efforts around reducing overdose or overdose prevention are focused on those actively receiving opioids from us. What this data shows is that we would be missing the vast majority of people who go on to die because really the population has changed substantially. The second question is that the risk, we probably have to develop a new and different understanding of who are the patients most at risk of overdosing now, because it might not be related to their opioid. So a lot of the studies that came out in the early 2010s and such really looked at the effect of the dose of opioids on risk of overdose. Now, when we take the opioid out of the equation, who are the other folks dying from heroin and illicit synthetic opioid overdoses? And finally, this really emphasizes that all of our overdose prevention efforts should also really focus on delivering evidence-based treatments to the populations at higher risk for overdose. So those using illicit opioids, illicit methamphetamine. What I did not show, which I should really emphasize in the state of California, is that in the state of California, as well as many of the states in the West Coast, the #1 cause of overdose death is actually meth. It's meth sometimes on its own, it's meth sometimes meth mixed with synthetic opioids. Sometimes the users know that they're using meth along with opioids, but in the vast majority of cases they don't know. So these are all, though, similar challenges, although the treatment options for meth are unfortunately far more limited. So that takes me to my second point around kind of major challenges currently. And that is, how do we deliver more treatment to those patients in need? So what you see here is a figure from a study published by Rebecca Haffajee, myself and other colleagues. And this is a map of the US showing all the counties in the country. In red are counties with not a single opioid use disorder treatment provider. That doesn't mean that counties like San Diego, where San Diego is, or Ann Arbor in Michigan, have sufficient number of providers. In fact, we really don't in Ann Arbor. I don't know what it's like here. It just means that there's a large swath of the country, especially rural areas, that don't have a single provider who can see patients. And this is one of the main reasons why.
These are OTPs, or these are
buprenorphine providers, OTPs, and Naltrexone providers in publicly listed databases, so on the SAMHSA website. There have been similar studies that have looked at it by specific medications. It's a very similar picture. And so alongside this, not only do we have access problems, we know that there are additional barriers to substance use disorder treatment. I like to think of them in the trifecta of stigma, the complexities of addiction itself, which most of us who work with this patient population know that it's a complex illness, right? Probably the most challenging part that makes it very hard for other people to understand, I think, is that the symptoms of the illness are behaviors. So it's behaviors of not wanting treatment, not wanting to stop using, and many other behaviors that can be very challenging. And lastly, though, I think that the biggest thing that we can really address in addition to stigma is really the limited access as well as the accessibility of treatment. And we know through surveys of patients with substance use disorders that these barriers are the ones that they also cite as the greatest barriers for them in terms of accessing treatment. The data on the right are from the National Survey on Drug Use and Health from SAMHSA. The one additional barrier that I want to really emphasize is one that I think we all frequently underappreciate within both mental health and substance use disorder treatment, and that's the distance barrier to treatment. In prior studies, distance has been described by patients as a major reason for discontinuing treatment. And like I mentioned before, discontinuing treatment is a huge problem because once they're no longer in treatment, their outcomes really deteriorate. It may be particularly challenging for patients in rural areas, which, like I showed, have even less access to substance use disorder treatment. One thing that I think it's really helpful for me as a clinician to keep in mind is that, a lot of the times we set up expectations for our patients. We forget some of the barriers that they might experience. So when I think about my patient population with opioid use disorder, the vast majority of my patients don't have access to reliable transportation. I'm thinking about my patients in Flint, Michigan, Detroit, Michigan, even in Ann Arbor. They don't have cars or working cars. And so what I'm really asking my patients to do is to take a combination of shuttles, public transportation, oftentimes for an hour and a half or more each way in order to come to my clinic and see me. I'm often asking them to do this at least once a week, especially initially, and then I'm asking them to do this indefinitely for a long period of time.
You're asking to be on time.
And to be on time, or else we won't feed them. So, for myself, I would have a hard time doing this, and then I can imagine that many of our patients who have many other struggles on top of all of this have really even additional challenges. So in a current qualitative study that I have, so it's aim 1 of my Career Development Award, where we're doing phone-based surveys of veterans with opioid use disorder not in treatment. We ask them, what are the major barriers? And these are specifically chosen in facilities that have great access to treatment. And what the veterans say, one particular veteran say, it's easy. I don't have a car. One of my favorite quotations from one of these interviews is that we asked a veteran who was in his 60s, had been using heroin for many decades, in and out of care for a long time. And I said, if you could think of anything, like the $1 million question, what would you do? And he's like, if you could make treatment as easy to get to as drugs for me, I'd be in treatment right now. He's like, I have to drive by, all of my friends and family members. So his social network are all folks who are actively using drugs. So they're not bad people to him. They're really the people in his life. And he says, sometimes I really get motivated to want to stop using, but it's really hard for me to continue doing so when it's so challenging. And so obviously this is a very difficult problem. I'm not saying that telemedicine is going to solve this, but it might be part of the solution at least when it comes to access. First, I want to define what telemedicine is and is not. So what I mean by telemedicine is what's called synchronous or live video conferencing. And it's pretty simple. It's using Skype technology kind of. So where I can sit in my office in Ann Arbor and see my patients who are located in Jackson, Michigan, or somewhere else, using just video conferencing software. And this has been done in mental health care for a long time. I don't know if the clinics here at UCSD have been doing it, but we've also been trying to develop it for other mental health treatments. What I'm not including in this bucket, at least for this presentation, are other forms of technology. So asynchronous and store and forward forms of telemedicine, so transmission of medical images and things like that, or other modalities such as telephone delivered, text-based, or other web-based interventions. And that's mostly because video conferencing delivered interventions are what's mostly reimbursable currently by Medicare, by private insurance, and by Medicaid. One thing I'd like to emphasize is the VA has long-standing been a leader in the area of telemedicine. It's really invested in the infrastructure of telemedicine. Brian probably knows this very well, is that a lot of the challenges around telemedicine are very basic to what we think of now in 2019. It's really having a camera that works, having kind of the information being able to see patients and being able to be plugged into the EHR system, being able to document accurately and capture kind of these encounters accurately. And so the VA has figured this out for decades, actually. The other thing that they have is the VA has both VA medical centers, like a very nice medical center across the street here. There's about 150 large VA medical centers in the country, but there's over 800 what are called CBOCs, or community-based outpatient clinics in the country. And the VA developed these for over many years to really expand access to primary care and mental health treatment in our community settings. And so what this allows is that you can see patients not only via telemedicine home, which is one potential option, but you can also use telemedicine as a form of increasing specialty care, because CBOCs oftentimes don't have substance use disorder treatment providers there. So there are different ways to use it. And lastly, one of kind of the newest initiatives within the VA, which I think they can do an even better job promoting, is the VA Video Connect program. And it really allows any provider to see any patient at home using telemedicine-based technologies. Before I talk about telemedicine for OUD, I just want to briefly emphasize that telemedicine has been a very successful and effective model for pretty much all other chronic medical conditions and mental health conditions. And this research has occurred over the last 20 years or so. So just two examples. One is one of the earlier RCTs of telemedicine for depression treatment. This intervention included both antidepressant med management as well as brief supportive counseling. They randomized patients to either receiving their treatment via telemedicine or in person by Ruskin and colleagues in 2004, and they found that there's no difference in depression outcomes. There's also no difference in dropout or patient satisfaction between the two arms. And this has now evolved to kind of the other end of the spectrum. So not just effectiveness-based studies, but really implementation-based trials have shown that telemedicine works pretty well. And not only does it work well, clinics, facilities can adopt it, can accept it, and can sustain it. So in a study by John Fortney and colleagues in 2012, they rolled out telemedicine collaborative care managed for veterans and CBOCs with depression. This occurred over multiple large medical centers and many, many CBOCs. They allowed localized tailoring of the intervention depending on the site. And most of the details of this are things that maybe Dr. Ahrens can talk about more than I can, but it's really kind of choosing different implementation strategies that are going to be most effective at the different sites. And they found that many sites really appreciated this. Over 90% of the CBOCs or the clinics chose to maintain the program after the research study ended. However, although we have really good evidence for telemedicine for mental health and other chronic conditions, there are probably some specific aspects of opioid use disorder and substance use disorder treatment to keep in mind. First, it is a pretty complex patient population. Most patients not only have multiple mental health, but also multiple other SUD comorbid conditions. And for them to truly do well, we have to think about not just delivering probably telemedicine for opioid use disorder, but how do you deliver these other treatments as well via telemedicine? One very simple logistic question is, how do you conduct urine toxicology screens when patients are, not at the same site? Third, and probably the thorniest issue to date, and one that I've been working on, is really that there are many additional layers of regulations at the state level, at the federal level, and then at the payer level that govern telemedicine delivered treatments, but also specifically telemedicine prescribing of controlled medicine, like buprenorphine. And then finally, how do we get more clinicians and staff comfortable with delivering telemedicine, especially among those who traditionally work in SUT settings, which that's been the last setting to have been using telemedicine in the first place. So we recently conducted a systematic review to look at the literature on telemedicine delivered treatment interventions for patients with substance use disorders. This covered from 1998 to 2018. It included published literature as well as gray literature, conference abstracts. We looked at any substance use disorder, including nicotine. And again, this was focused on that kind of real-time treatment delivery. So it didn't include like text messaging or like web apps or anything like that. And we looked at a host of different outcomes, including treatment adherence, acceptability, satisfaction, things like that. We also included a wide array of study types, so not just RCTs, because we realized very early on there were very few RCTs, but we also included experimental, quasi-experimental, and mostly observational studies. Though we excluded single case reports and commentaries. We found in total, over this fairly long period of time, there were only 13 studies that looked at telemedicine for substance use disorders, 3 for tobacco, 5 for alcohol, and 5 for opioid use disorder. Most were in the US, a few in other countries. Sample sizes ranged widely because we also included the observational studies. This was also a study published recently in the Journal of Substance Abuse Treatment. What we found, I will focus on those studies that focused on opioid use disorder treatment. 2 of those studies specifically focused on delivering a psychotherapy-based intervention. Both of these were delivering psychotherapy interventions to patients receiving methadone, and they were to patients at home. Very small sample sizes. They found no difference in number of sessions attended, no difference in drug-positive urines, and no difference in therapeutic alliance, which I think is an important thing to look at. Then there were additional 3 other studies looking at telemedicine, which included a medication component. All 3 of these, though, happened to be non-randomized studies. They examined either buprenorphine or methadone treatment. In all 3 of these studies, patients were not at home, but they were located at a rural, distant clinic site. The first study, I'll just mention all 3 of them. First was conducted in Ontario, Canada, which has actually been doing telemedicine for methadone for many, many, many years. And they found that the video conferencing or the telemedicine group were more likely to be retained in treatment in 1 year compared to those who received the majority of visits in person. Again, this was not randomized, they just looked post hoc. A study by folks in West Virginia had similar findings. They found no significant difference in time to abstinence and retention comparing patients receiving buprenorphine in person versus telemedicine. And the last study by Weintraub and colleagues at Maryland found similar retention, 50% retention at 12 weeks, though they did not have a comparison arm. So in summary, the evidence for telemedicine is really robust. I did not really capture this, but really there are many systematic reviews, meta-analysis for telemedicine for mental health conditions. However, the evidence for substance use disorders is much more limited. Doesn't mean it's not effective, it's just not been looked at as much. There are some indicators that the therapeutic alliance retention is, could be pretty comparable, though the sample sizes are really very small. And really kind of the barriers that some of these studies cited were, it's not about whether or not patients can engage, it's really the logistics. Can we get the technology at home working? What about when it breaks? What if it's, the therapist is not there? Like, it's really not about kind of quote the science, it's really about the detailed logistics of sustaining a program like this. And of course, it's really important to, whenever we're thinking about these interventions, to compare to the most relevant comparison arm, which in some of these cases, it's really no treatment at all. And what I would say is that there are a number of future studies needed, including further understanding patient-provider perceptions on whether or not they would adopt telemedicine, additional randomized controlled trials, both looking at the effectiveness of treatment, but also implementation studies. So can we integrate this into real-world clinic environments, especially including the medication treatment component, comparing telemedicine to patients in clinics versus those at home, and also really thinking about the quality of care, comparing telemedicine to in person. So I have the opportunity to assess and address some of these questions in my Career Development Award, which is a 5-year award, so I have another 4.5 years in that. All right, so third challenge. I'm actually very happy to take any ongoing questions, too. I know some folks have had a chance, but I forgot to mention that. The third, and this really relates to some exciting projects that I wanted to mention because I think it might relate to some interest in folks in the audience. It's the question of how do we support providers, both current providers who are not using these treatments or current providers who are, but helping them deliver more treatment to more patients. We have studies from a number of survey studies from myself as well as colleagues where we surveyed clinicians nationally across the U.S., different subpopulations, rural clinicians, urban clinicians, clinicians who are primary care versus mental health care versus substance use disorder. We asked them to describe the barriers for them to utilizing these forms of treatment. And the consensus is pretty clear. They describe that the availability of additional psychosocial treatments is very rare in many communities in the country, especially for those patients with both OUD and comorbid mental health disorders. They also cite that they feel, even though, like I mentioned, to deliver buprenorphine treatment, you have to go through some additional training, which is only 8 hours for physicians. This doesn't seem adequate for some folks, and that's understandable. So where can they obtain additional training? Clinic supports is a huge thing. So within clinics that have not been traditionally delivering OUD treatment, how do they get their nurses on board, their MAs on board? How do they get their administrators to kind of support this form of treatment? And finally, for difficult cases, how do they have access to expert consultation? Because UCSD might have a few notable addiction psychiatrists, but not all healthcare systems. And in fact, very few healthcare systems in the US have access to addiction expertise. So we sought to address some of these issues in 2 different projects that I'll mention. One is really a state partnership, so this is not a scientific research study. This was funded by SAMHSA and implemented through the Michigan Department of Health and Human Services. we created two kind of sister programs. One is called the Michigan Opioid Collaborative, and that's kind of a multi-pronged intervention where we expand access to these X-waiver trainings. So we have maybe 6 or 7 a year in different parts of the state in rural areas, so you can have a group of rural docs together. We also provide training on other clinical staff, so nurses, MAs, and things for them to understand how to support these treatments. Very importantly, this program funds a master-level social worker to be stationed in different counties and regions across the state of Michigan so that they can help connect, they meet the local providers in that area, and they help connect those local providers to resources in that clinic or in their particular area, and they understand the issues. So for example, our behavioral health consultant in rural Upper Peninsula, right, which is 12 hours from where I am in Ann Arbor, lets us know the very particular challenges that are there in rural UP, which is mostly meth use, which is diversion issues are bigger there. So thinking about those two issues in a very local context. And then these behavioral health consultants connect providers in the community to folks like me who take phone calls. So I answered a phone call earlier today from a provider. And so any provider who gets kind of signed up to our program, which is free for them, have access to same-day consultation service from an addiction clinician. We don't see the patient. They describe to us kind of the clinical details, and we provide kind of verbal recommendations. The sister program to this is our Michigan Telemedicine program. And with that, that's really to kind of address the psychosocial treatment component, which we also know is very much absent in most parts of our state as well as the country. So there's very little access to evidence-based cognitive behavioral therapy interventions for substance use disorders. So what we've developed is a phone-based counseling, time-limited counseling intervention that can be delivered by our therapists to patients located anywhere in the state. In order to specifically focus on patients with opioid use disorder receiving medication treatment. And we're also developing ways to provide video conference-based consultations to community providers as well.
And how many sessions are provided and how long
So
will it continue?
that's a good question. So in this program, we're focusing on the first couple months of treatment. So it is time limited. And usually they're weekly based counseling sessions. We've developed the manual based on CBT for relapse prevention, but we've also incorporated additional kind of components to really focus on the opioid piece. I don't know if it's true in California, but in Michigan, there used to be a requirement for Medicaid patients that they have to put down the fact that they're seeing a therapist. And so that was one of the major challenges in patients, or in providers doing this when there are no therapists around. And so we designed it in a way that they can probably list us if they wanted to say, you know, my patient is seeing this program at the University of Michigan. In parallel, but slightly in contrast to this program, I am also co-PI of the NIDA R01 trial along with my colleague, Dr. Mark Ilgen, who's a clinical psychologist. This is really more trying to understand the science of it. So the first project is let's just deliver it. And the second is how do we improve the interventions that we can deliver? Because like I mentioned, a lot of folks with OUD also have chronic pain. And that subpopulation can be a very complex population to manage. And so we've developed a psychosocial, also cognitive behavioral therapy and ACT-based pain management intervention tailored for patients with opioid use disorder and chronic pain starting buprenorphine treatment. So these are patients within their first 3 months of treatment with both pain and OUD. And the intervention both helps them kind of manage pain as a traditional pain CBT intervention does, but also additional components around managing their buprenorphine. How do they engage with their clinic better? Because what we find is that a lot of patients drop out of care, not because they want to, but also potential there might be clinic policies such as use of marijuana or something like that that leads them to drop out. So how do they kind of better negotiate those relationships with their clinic? And so this is a phone-delivered intervention as well over a 1-month period with 8 sessions, and we're going to be looking at outcomes 12 months afterwards. We're recruiting both a veteran population as well as a community population. Finally, lastly, I'll just mention a lot of different things, but the one area that, although it's the last thing, I only have one slide on it, I honestly think this is the most important thing, and that is even though, as a country, we're increasing primary care providers, psychiatrists who are delivering buprenorphine treatment. Ultimately, the question we haven't answered or really thought carefully about is, what is the quality of care and how do we improve it? Like I said, anybody I think who's spent any time in a substance use disorder treatment setting probably appreciate that treatment varies. You see me versus you see another provider, recommendations might be wildly different, right? And that's in part because we've had very little evidence to guide what treatment practices are going to be more effective or not. For example, is it better to keep a patient who's actively using marijuana on their buprenorphine, or is it better to discontinue that patient? This is very actively debated. It's hard to do a randomized controlled trial on this, but we can look at these questions using observational data and survey data. And so I have a project underway where we're utilizing surveys of buprenorphine providers to understand how they practice and then linking that to patient outcomes. So we have a better understanding what is going to be a better approach to treatment and for which patients. Because it might be that certain approaches might be better for some patients, whereas others are going to be worse for other patients. And we're able to link this to our VHA patient data to be able to link it to overall patient outcomes. I'm also smiling at those in the audience who might be buprenorphine providers where the survey is going to be distributed to. So I hope you oblige my research question in this. And then that is pretty much the end of what I wanted to discuss. Many thanks to funding support as well as to mentors and collaborators who are listed here, Drs. Blow, Ilgen, Bonner, Medson, and Dr. Gordon. Thank you very much. Happy to take any other questions.
So interested in what you're saying about changing attitudes or affecting attitudes, and one of the areas I work in is how do you change the climate of an organization strategically to support this process. And I really like that you talked about it's not just the physicians, but it's the MAs, it's the receptionist. I mean, can you talk a little bit about your experiences with variability and kind of some of the clinics you've worked with and kind of the good stories and the not so good stories you might be able to share?
There's definitely huge variability there, as I think anybody who's worked in a clinic have seen, and as we can all appreciate working in any organization, right? And so thinking about, challenges and also successes. Challenges, for example, telemedicine is a particular challenge because there's the additional logistics of, in the VA, we have a TCT, a telehealth, telemedicine treatment coordinator in different CBOCs. We have to have that person aligned with the triage folks, and then that person might not always work, and whether or not they want to start doing, adding something additional to their plate. I mean, our system is not incentivized to do that, right? There's no incentive for someone to add something new to their plate. And so kind of how to work with folks to help them be in alliance with treating patients better, but also understand that you can't just make things much more difficult for them and expect them to happily do that. So I think those are some of the challenges that we're currently facing. Some of the success stories. So one of my colleagues, her name is Shiva Sethi, I should have her up there. She is a family medicine doc who trained in the Bronx, mentioned this to Carla earlier, fairly young physician, and she was trained in a program where it was kind of part of the course that everybody treats. Primary care docs treat opioid use disorder, stimulant use disorder, Hep C, HIV, right? Of course you use buprenorphine in your clinic. And so she comes over to our healthcare system where this has not traditionally been the case. And she goes into a primary care clinic, and it was very challenging for her, honestly, to try to convince her MAs, her nurses and such. But interestingly, over the course of about a year and a half or so, she was able to convince two of her other physicians to get X waiver, though they didn't start prescribing. But more importantly, she was able to create an alliance with a nurse in her clinic to help support her delivering buprenorphine treatment. And that was really just kind of talking to her about why it's important to do this, what are the outcomes, and most importantly, to show her that these patients are not like the other patients. These are patients who can do very well when they're doing well, right? A lot of clinics, especially these days, are challenged by the fact that chronic pain, patients on high-dose opioids can be very challenging, especially when we now taper them off of their opioids. And so they're used to thinking, oh, this is going to be a very challenging patient population. But when you can show folks that there are interventions you can deliver that can really improve outcomes and have them be a partner in that, that can be, I think, helpful in certain situations, not with everybody though.
Thank you very much for your talk. It was very interesting. I'm interested in their patient outcomes and how can you measure the patient outcome? So could you let me know some objective examples of the patient outcome?
Yeah, so when I think about patient outcomes for opioid use disorder treatment, there are both kind of examples probably lie in two camps. One is secondary data and one is primary data collection, right? I'll start with secondary data because I work a lot with that, which is EHR data, administrative data. So in the VA, we collect data on all healthcare utilization. Did they go to the emergency room? What was the cause for them going to the emergency room? Inpatient hospitalizations, infections, Hep C, HIV diagnoses, and things like that. And also treatment utilization. Did they require additional treatment? And then we also have what were the causes of some of those? So did they have an overdose event? Both measured from hospital utilization records, but also from mortality data. So among the veteran population, we're able to link all veterans to cause of death data. So the other layer to that is prospectively collected outcomes. And what I would say are the important kind of outcomes to think about when you're thinking about looking at the impacts of treatment are not only things around traditional, research outcomes are things like abstinence, right? Like 30-day abstinence or time to abstinence. But really, I think the things that we probably should be thinking more about, in buprenorphine treatment, this has been thought about. The primary outcome from a lot of the studies, including our R01, is actually retention and treatment. So we are measuring substance use. We're collecting urine drug screens. But honestly, how important do I think that is? Maybe, maybe not, because they're already doing that in clinic. But we're really looking, the primary outcome is retention and treatment. Because like I mentioned, when people drop out, that's when bad things happen. But in addition, it's important to collect a lot of other functional outcomes. So around pain management in particular, right? It's not the pain score that I care so much about. It's how do they feel about managing their pain, their confidence, their self-efficacy, pain catastrophizing. Those are the metrics that we're also collecting, and pain acceptance as well.
Why are patients happy with telemedicine? We've been told our whole lives in medicine that the doctor-patient relationship, the alliance, whether it's in medicine, psychiatry, is paramount. And now people are liking telemedicine, which I would think would be a dilution of the doctor-patient relationship.
So I can speak to that. So I actually provide telemedicine at the Ann Arbor VA to patients, to buprenorphine patients. It's not a large group of patients, but I see patients up to our Flint clinic. And so the way that I've talked to, I don't require them. They can always come to Ann Arbor and see me, right? It's always an open door. You can see me in person, or I can see you via telemedicine to this clinic. And some of the patients were like, oh, I like coming and seeing you. Most of our patients, especially on buprenorphine treatment, I've seen more visits than any other patient population, right? I've had 30 encounters with them over a 2-year period. But for patients who end up switching to telemedicine, and all of those who switched have stayed in telemedicine, they say it's pretty much the same. And this is a population, I see older veterans, I see younger veterans, but most of them are used to Skype, they're used to FaceTime, they're used to some forms of communicating with people through those technologies. But also, there's a clinic there. They now know the nurse there, they know the MAs there, they know the TCTs. They also, about 6 months ago, the cohort of veterans I have there told me they formed their own group, their own patient group, a support group, so not AA, but they actually stay after me seeing them, and they talk to each other. So they were able to hold on to many of the facets of treatment that really appeal to them and connected them to me. And I already did have a relationship. So what I don't mention is that in those group of patients, I did the induction in person. I saw them in person first, and then I transitioned them to telemedicine. In the VA, there's a lot of facilities, and we're also thinking about this, in Montana, right? Patients have to drive 6 hours. There's no way you can even do an initial in-person visit. So how do you do that? And I think the ultimate answer has to do with my last bullet point on one of the slides is what is the comparison? What's the alternative? If the alternative is really no access to care, then a patient will say, and then having to drive 6 hours, then a lot of patients will elect to see their providers via telemedicine.
Or it'll be an interesting study in terms of the continuation of treatment of those who go to a C-box and experience just what you described.
Yeah.
In comparison to those who would just do telemedicine with them at home.
Yep.
Through their home connection.
Yeah.
I think we probably have an expectation, but who knows?
We don't know. So that might be an aim 2 of my career development award. I think there's one more question.
Thank you. That was an excellent talk. Staying on this telemedicine theme, and are you doing the telemedicine entirely within the state of Michigan's, allowing you to prescribe? Are you so in the VA system where federal licenses can cross boundaries? Are you familiar with any programs where a provider in Michigan could somehow prescribe buprenorphine to a patient in Montana?
I could probably speak another 30 minutes on this topic. So I alluded to the fact that there are many layers of regulations. Within the VA, we have, in some ways, an easier time, in some ways, a harder time. So I'll mention one very key piece of legislation, it's the Ryan-Haight Act. It's a federal rule that came out that it wasn't really specific. It wasn't supposed to specifically be related to telemedicine, but it's been applied to it. And that means that for a patient to be seen via telemedicine, they had to have an initial in-person visit. Right? And this is a federal rule that applies across all states. There is a VA exception in that rule. However, the VA has not really interpreted it as an exception. The guidelines from the Office of Rural Health and Office of Teleconnect in the VA has implied that we should still utilize this rule except for a couple things. For patients seen in C-box, because C-box all have their own DEA registration at this point, and every facility can check on their own, they don't have to adhere to this initial in-person visit. However, if you want to see a patient to home as the first telemedicine visit, you can't do that. You have to have the initial in-person visit. Going to your question of across state lines, colleagues, and I'm actually presenting with them on Thursday at the American Academy of Addiction Psychiatry Conference in San Diego. Colleagues in Connecticut and other places have been doing across state lines because the VA has actually developed what are called telemental health hubs. So there's a hub in each VISN, and they're really there theoretically to provide short-term care, primary care, mental health care, substance use disorder care. Some of the hubs, my colleague Dave Moore, who's the director of VISN 1 hub, has been doing telemedicine buprenorphine across state lines, so from Connecticut to Maine to New Hampshire. It's challenging because the additional layer there are state regulations. And the VA has not elected to put out a statement that says the federal supremacy rules in these cases. So in those cases, the provider has to still follow all rules in both states. And so this can be done for Maine, but they found it really prohibitive, and they've not been able to see patients in the state of New Hampshire due to particularly restrictive rules for telemedicine there. So it's very state specific.
So if you did that, you couldn't prescribe in that state. You'd have to prescribe at a VA facility that mails you the medication.
Oh, that's a whole other layer. Yeah, transport of medications is a whole other issue. So what I'm saying, I guess, in those cases are that it is possible to do telebuprenorphine across state lines, across certain states, but you have to check with your state regulations. You can't do it to patients at home. They have to come into a CBOC. Getting medications to patients is an additional challenge, right? We mail patients overnight via UPS at the VA. That's how I get medications to my telemedicine patients. Doing it across state lines sometimes has additional issues. Where they can pick up that medication has some additional issues, and then where the patients can do their urine drug screen. Some VAs have elected to have their patients pick up at different pharmacies, have done labs at like Quest instead of the VA. So there's different ways of getting around it, but most of the issues are really logistics. It's not really about science at that point. Yeah. Thank you very much.
Thank you so much.